Hello, students and dear colleagues. Today we'll talk about reproductive health. Reproductive health is very important topic, and this is very interdisciplinary also. This topic is studied not only by students of sociology, but also by students of social work, then gender studies, and community medicine, as well as other social sciences. The contents are also almost similar here because here we have to deal with facts and specific stages of life. So things are more conceptual and factual here. Uh, we need to understand difference between reproductive health and maternal health. Very often students ask me that what is the difference between these two things. We'll talk about these things. Uh, at the outset, I can talk about this even to, as of now also. Basically, reproductive health talks about health of people during their reproductive span. We know that all biological beings have reproductive span. So we talk about health of the biological being during this reproductive health kind of thing. But here we focus on human beings, right? Now, males and females both could be included when we talk about reproductive health because both participate in this reproduction process. Uh, all biological beings, including human beings, have a specific reproductive span. Then uh, the focus here is on specific practices and specific requirements related to reproductive or reproduction. Reproduction is very important process for continuation of human race, or you can say species. Every species is maintaining itself in this planet through the process of reproduction. So for the future of the present generation, we need to have this process of reproduction. So this is very important. Maternal health is exclusively focusing on the maternity experiences, right? So whenever we talk about maternal health, often we also take into consideration health of the children also because it is related to the maternity experience. So basically, the focus is on pregnancy, then childbirth, and then healthcare of the mother as well as of the children. Reproductive health, on the other hand, goes beyond these things. It talks about safety, or you can say safe sex. It talks about the use of contraceptives. It talks about infertility. It talks about the outcome of pregnancy in multiple forms like miscarriages or abortions, kind of thing. So the focus is on the reproduction process in reproductive health. Then it is spread over the entire reproductive span. And we know that every biological being is having a specific reproductive span. So these things are the larger concern. One important thing that we need to know and we need to understand is this, that reproductive health is a recent term, and the focus here is also related to population control. So I have prepared my slides for this topic, and I'm going to share the screen so that we can have a systematic understanding of all these issues. So in this topic, we will cover 4 sections: understanding reproductive health, need of reproductive health with reference to ICPD conference, then MDG, that is Millennium Development Goals and Reproductive Health Targets, and policies and programs in India and the main achievements. So how do we define reproductive health? Or where from the concept of reproductive health is coming into the context? For that, we need to go to the decades of 1990s. The term reproductive health was first adopted at the International Conference on Population and Development in 1994. This conference was held in Cairo, Egypt, from 5th to 13th of September 1994. And it was participated by multiple agencies, basically representatives from various governments, and then UN agencies and NGOs have participated. And it was agreed that that the findings or the conclusions of this conference will remain applicable for next 20 years. That means at the time of its organization, it was realized that the outcome are going to be very important for the next 2 or more decades. ICPD has left a landmark legacy and remains an essential tool in work to improve the sexual and reproductive health globally in the aftermath of arrival of HIV/AIDS and RTI and STI. So this is an important thing. Basically, when we talk about the 90s, then we cannot forget 80s. And during the late 80s and early 90s, the world was witnessing the spread of serious and severe problem known as HIV, AIDS. HIV, that is human immunovirus, and AIDS, that is acquired immunodeficiency syndrome. So as the world is witnessing COVID-19 today, in the late 80s and early 90s, the world was witnessing the problem of AIDS, and it is primarily because of the problem of AIDS and HIV that the sexual health has become very important at that point of time. And the concept of reproductive health is actually taking into consideration the issues related to RTI, that is reproductive tract infection, then STI, that is the sexually transmissible infections, and STDs, that is sexually transmitted disease, and HIV/AIDS, and other related population issues. So this reproductive health at that point of time is talking about several interrelated problems and concepts. And that is why it is very important. And the relevance of this is continuing even today. The notion of reproductive health shows a holistic and healthcare approach toward the problem of population growth and says no to rigid and severe population control measures. Now, this is another important aspect, and that is why I've included it here. Basically, the world has witnessed the problem of population growth. Since the Second World War, one of the important concern of most of the developing countries, or the third world countries world over, remained population control. And in the 60s, 70s, and 80s, several experiments were made. Even in India, we know how very severe population control measures were adopted. But we realized that those severe population control measures, or you can say the instrumentation of vasectomy or tubectomy kind of thing, those have not proved very productive, or they became counterproductive. So the whole approach was changed. A healthcare approach is adopted. And so this conference on population and development is becoming very important, because it has redefined the whole strategy, the whole conceptualization. In the ICPD program of action, reproductive health is defined. So when this is the most comprehensive and authentic definition of reproductive health as proposed during the ICPD conference. Now we need to read this definition. A state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity in all matters relating to the reproductive system and its functions and processes. Reproductive health therefore implies that people are able to have a satisfying and safe sex life, and that they have the capacity to reproduce and the freedom to decide if, when, and how to do so. So this definition, as proposed during the ICPD conference, is very straightforward, talking about the safe sex life, and then the capability to reproduce, and then the freedom to decide when and how often to do so. So the freedom to decide. Now we need to understand this statement, the freedom to decide if, when, and how often to do so, with the pre-existing concepts of population control or family planning, in which the state was showing to have massive control over the process, right? Here, the focus is on the individual, and the decision is primarily lying with the individual, right? That means there is change in the focus, and that's why I'm saying there is a healthcare approaches there. Implicit in this last condition are the right of men and women to be informed and to have access to safe, effective, affordable, and acceptable method of family planning and family planning of their choice, as well as other methods of birth control. So it is very clear here that any measure related to family planning or birth control is primarily a decision of the concerned individual, and their choice should be there. The state should not have a controlling position or dictating position as it happened earlier in India. Also, we have seen such things during the decade of 1970s. And then a right of access to appropriate healthcare services that will enable women to go safely through pregnancy and childbirth and provides couples with the best chance of having a healthy infant. So it is related to procreation, having the birth of a child, then all other related experiences. Outcome of ICPD in terms of reproductive health. The ICPD achieved consensus on 4 qualitative and quantitative goals for the international community, the final 2 of what have particular relevance for reproductive health. So what was the overall outcome of the ICPD conference? The ICPD conference had several outcomes, but here we are talking about 2 specific outcomes which are relevant from the perspective of reproductive health. The first is reduction of maternal mortality. A reduction of maternal mortality rate and narrowing of disparity in maternal mortality within countries and between geographical regions, socioeconomic and ethnic groups. So what is this maternal mortality rate? Basically, during the process of birth of the children, very often mother die. This is known as maternal mortality, and there is a specific rate, total number of deaths during childbirth or after 6 weeks because of any issue related to childbirth. This is known as maternal mortality, and it is calculated per 1 lakh population. Right, we'll come to this at a later stage also. But in India, or for that matter, developing countries or world over, we have seen that number of women were dying during this childbirth experiences. So because of several complications during the process or because of a lack of resources available during the process. So this is an important concern, that is maternal mortality. One of the specific outcome is this, to have control over or to reduce the maternal mortality. So the second one important outcome is access to reproductive and sexual health services, including family planning. Now, this point actually covers several things, and I have highlighted all these things in different colors. I'll try to make you understand all these things in simple words briefly. So family planning counseling, basically, when we talk about family planning, it means size of the family. So a small family, that is family planning, is what is generally understood. Then prenatal care, basically after pregnancy, several kinds of care is supposed to be provided to the pregnant women. This is known as prenatal care or antenatal care also. Then safe delivery. When the mother has conceived the child, then this delivery should take place in a safe environment. And then after the delivery, some kind of care, all required care should be provided. This is known as a postpartum care or postnatal care also. Prevention and appropriate treatment of infertility. Now, there are women who are men and women who are unable to conceive. So this is known as infertility. Now, motherhood or fatherhood is a biological right of every individual. So There should be proper and appropriate treatment of infertility also. And as of today, we know that there are several other parallel mechanisms. In vitro fertility is one such intervention. And then as of today, we also talked about some other uh, mechanisms also. Then prevention of abortion. Now this abortion is again an important issue here, because it talks about some termination of unwanted or medically unfit pregnancies. Then management of consequences of the abortion. Then treatment of reproductive tract infection. This is the RTI. As I stated that during this reproduction process, many persons often get infected with several types of RTIs. Now, along with these RTIs, there are STIs and STDs also. One important thing we need to remember here is that because of the arrival of HIV/AIDS, these RTI and STI became very important, because this is increasing the vulnerability of a person to get infected with HIV/AIDS. So pre-existing RTI or STI increases the vulnerabilities, and that is why these things became very important at this point of time. Then education, counseling, and then as appropriate on human sexuality, reproductive health, and responsible parenthood. So counseling of all those persons who are in the adolescence or who are going to have this role of being parents. Then services regarding HIV/AIDS, breast cancer, infertility, delivery, hormone therapy, sex reassignment therapy, and abortion should be made available. All these things which are related to the different needs and requirements during the reproductive span should be made available. And then active discouragement of female genital mutilation. So there are practices of genital mutilation in several cultural contexts that also needs to be discouraged. The purpose is to talk about all the possible needs and requirements of people during the reproductive span in a very open way, so that there is kind of socialization of people also, so that there is kind of learning of people also, so that there is an appropriate friendly ecology is prepared, in which uh, reproductive health and health of the mother and health of the newborn baby could be taken care of. Then we know how to move forward. Basically, once this concept of reproductive health is conceptualized, then the next important issue was this: how to move forward. And for that, basically, the Millennium Development Goal became very instrumental. We know about MDGs, and we'll talk about MDGs in a separate topic also later on. But let me tell you here that basically 191 UN member states agreed to achieve this Millennium Development Goal. These were incorporated at the turn of the millennium, and these were primarily sought to be achieved by 2015. There were 8 Millennium Development Goals to eradicate extreme poverty and hunger, to achieve universal primary education, to promote gender equality and empower women, to reduce child mortality, to improve maternal health, to combat HIV/AIDS, malaria, and other diseases, to ensure environment sustainability, and to develop a global partnership for development. Out of these 8 goals, 5 are related to health, and out of these 5, 2 are exclusively related to the notion of reproductive health. This is goal number 5, to improve maternal health, and goal number 6, to combat HIV/AIDS, malaria, and other diseases. We'll not talk about malaria and other diseases, but we'll keep focusing on HIV/AIDS here. So goal number 5 and 6 are exclusively dealing with the reproductive health issues. Now, I have mentioned the goals and the specific targets here. If we go through those Millennium Development Goals, we happen to find that the goals are there, then specific indicators are there, and then specific targets are defined. So the targets are given in terms of numbers also, and sometimes you may find that there is some kind of discontinuity between number of goal, the goal number and the target, but I have mentioned it exclusively here, the way it is given. So goal 5 is to improve maternal health, and this is target number 6. Goal 6 is combat HIV, AIDS, malaria, and other diseases, and this is target number 7. I'm talking about target number 6 and target number 7 because when we go for assessment kind of thing, then these target numbers will appear time and again. So within this goal number 5, there are two basic indicators. Reduce by 3/4 between 1990 and 2015 the maternal mortality ratio. And then the second one is universal access to reproductive health. Right? When you talk about universal access to reproductive health, then 4 points are there: contraceptive prevalence rate, then adolescent birth rate, then antenatal care coverage, and then unmet needs of family planning. Now come to the next goal, goal number 6. This is combat HIV/AIDS and malaria and other disease. This is target number 7. And here again there are specific target. So have halted by 2015 and begin to reverse the spread of HIV/AIDS. That means complete control over HIV/AIDS by 2015, and then achieve by 2010 universal access to treatment for HIV/AIDS. So basically, both the targets are related to first is treatment of HIV/AIDS and then complete control of HIV/AIDS. So these were the basic goals as developed in the MDGs. And then Millennium Development Goals have different outcome in different countries, different parts of the world. India has also incorporated those goals, and the outcome is provided periodically. This is the country report of India and the final country report on MDGs, basically provided by Government of India in 2017. I have included here the assessment of the government on these indicators, primarily focused on issues related to reproductive health. But basically, this country report is addressing to all the 8 goals. So anybody who is interested in these details can go through, you can pause the slides and go for these details. Maternal mortality ratio. Now, I talked about this earlier also, but it is properly defined here. The maternal mortality ratio is the number of women who die from any cause related to or aggravated by pregnancy or its management, excluding accidental or maternal mortality ratio is the number of women who die from any cause related to or aggravated by pregnancy or its management, excluding accidental or incidental cause during pregnancy and childbirth, or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, per 100,000 live birth. We talked about it earlier also. Now, quickly, some of the figures. In India, pregnancy-related death of women have declined over the years. Here I have mentioned point number 7.4. Actually, this is taken from the country report. So you can find these points in the country report of 2017. That is why I'm retaining these points. Point number 7.4, 7.2, 7.5. These are taken from the country report. So you can find these points from that country report also. Now, the MDG 5 stipulates that MMR level be reduced by 3/4 between 1990 and 2015. In 1990, the estimated MMR was 437 per 1 lakh live birth. In order to meet the MDG target, MMR should be reduced to 109 per 1 lakh live birth by 2015. As per the latest estimates, the MMR status at all India level is 167 in 2011-13. So we were supposed to reach to the goal of 109 per 1 lakh or 100,000 population, but we could not reach to this. There is some kind of shortage in achievement of this goal. We can see that there is a huge disparity in terms of the states. Kerala has 61 and Assam has 300. That means the disparity is prevailing. The performance of various states is also mentioned here. Then next indicator is proportion of birth attended by skilled health personnel. So many women die, maternal mortality is high because of the death due to death during the childbirth process because of lack of skilled health personnel. And one of the goal is to provide skilled health personnel, right? Institutional delivery is basically what is SoH, and very often trained persons or DIs could also be provided to assist the birth process. So the state of Kerala, Lakshadweep and Puducherry have achieved 100% coverage in birth attended by skilled health personnel in 2015-16 as per NFHS 4. 13 states reported that more than 90% of the births were attended by skilled health personnel. That means in India, we can see that there's specific achievement related to this. Although this has created some kind of different types of problems, I've addressed some of those issues in the later part of this lecture also. Then several programs and policies were actually incorporated. I will not talk about this policy, but just for reference, I mentioned some of them. Some of these promotion of institutional delivery through Janani Suraksha Yojana, then building on the success of Janani Suraksha Yojana scheme, then a Pradhan Mantri Surakshit Matritva Abhiyan. These are different schemes and programs which were launched to achieve those targets and goals. Then one of the important indicator is condom use rate of the contraceptive prevalence rate. Basically, use of contraceptive or condoms. So some of the specific achievements are mentioned here. Then antenatal, then intranatal and postnatal care, including iron and folic acid supplement to pregnant and lactating women. And then unsafe abortion being the third largest contributor. I mean, some kind of provision to control and manage the unsafe abortions. So all these goals, which are the targets of the MDGs, have been discussed here. Anybody who is interested in these details can go through or can refer to the India country report also. Then let me very briefly address some of the other issues. As I was talking about the birth processes. So institutional birth is an important mechanism. I have included some of these slides from my other presentations. These are the latest data provided by NFHS 4, National Family Health Survey 4. So this anybody who is interested in seeing the prevalence of institutional birth means when the childbirth is taking place in some formal institutions where some kind of formal help is available. Medical services are also available. It may be a government healthcare center or it may be a private healthcare center, but some kind of clinical environment is there. Institutional birth is like that. We see that in Kerala, Tamil Nadu, Goa, and Andhra Pradesh, there is highest institutional birth. But in several other states like Bihar, UP, and Arunachal Pradesh, still there is gap between the target of 100% institutional birth and what is prevailing. So the goal of 100% institutional childbirth has not been achieved till recently in many states. The growth of institutional delivery is followed by a twofold increase in cesarean section delivery. Now, this slide, the word cesarean section delivery is not visible. Cesarean is basically an operated delivery, basically some kind of surgical work is actually conducted, and this is known as cesarean delivery. Now, what is happening that with the institutional delivery, the cesarean section delivery is also increasing. And if you go by the numbers, we happen to find that the growth in institutional delivery is followed by a twofold increase in cesarean section delivery from 8.5% in 2005-6 to 17.2% in 2015-16. Now, if you see this growth from 8.5% to 17.2%, then this appears to be very nominal. But if you see these rates in some specific states, for example, Andhra Pradesh, Kerala, Tamil Nadu, Jammu and Kashmir, and Goa, we happen to find that these rates are very high. In Andhra Pradesh, 40%, Kerala 35.8%, Tamil Nadu 54.1%, Jammu and Kashmir 33%, Goa 31%. So this proportion is actually very high. And as per the WHO guidelines, in any population at any point of time, the required number of cesarean section delivery because of medical reasons is supposed to be around 15%. But we can see that these these percentages are much higher than the standard 15%. So these figures suggest that there are cesarean section deliveries caused because of reasons beyond those medical reasons. And yes, we have published work on this particular topic, and we have identified several non-medical reasons or causes of this cesarean section delivery. Anybody who is interested can go for that paper also. And then private, actually, the slides are the titles were not visible. That's why I have to go for this. Birth in a private health facility delivered by CS. So when we talk about cesarean section delivery, so this was the previous slide, that the title was not visible. And then this is the second one, birth in a private health facility delivered by CS. When we go by the number of cesarean section delivery, we happen to find that in private hospitals, these numbers are very high. Now, this is a very serious issue, and I think the policymakers need to take into consideration that why is it that in private hospitals the number of cesarean section delivery is becoming increasingly high. This is a serious consideration, and as I have mentioned here, it is important to note here that WHO suggests that CS rate above 15% in any society is unnecessary, right? Because it cannot be validated because of medical causes, right? Then states with highest and lowest percentage birth in public health facility delivered by cesarean section, and then average out-of-pocket expenditure per delivery in public institutions. So although I've provided the figures here, but this is anybody's guess that the expenditure of cesarean section delivery is much higher in private hospitals. So the last point is the Millennium Development Goals. Basically, the Sustainable Development Goals were incorporated in 2015, and these are supposed to guide us till 2030. And several goals in the SDGs have been incorporated in such a way that they can address to the issues related to MDGs. And primarily out of these 17 goals, many talk about health of women, maternal health, or reproductive health. The approach is slightly changed here because here the focus is on health and well-being of women as a whole, and not talking about the specific phases of life because of the achievements made during the Millennium Development Goals. So we can identify some of these goals. Goal 1 talks about ending poverty in all forms. Goal number 2 talks about hunger, then achieve food security and improve nutrition. and promote sustainable agriculture. So this goal number 2 is very important, because if you focus on improving nutrition, then certainly nutrition of mother as well as child could be taken care of. One important point that I need to talk about here is this, that health of the mother is very meaningfully related with the health of the newborn babies. Basically, in India or several developing countries, there is high prevalence of neonatal mortality or infant mortality. And actually, this infant mortality and neonatal mortality cannot be controlled completely unless we take care of the health of the mother, because there are so many things which are genetically related. And we know that the first few months the child is the newborn baby or the unborn baby, basically in the form of the fetus or in the form of the baby, is remaining inside the mother in the womb and nurtured by the mother. So health of the mother is directly responsible for the health of the unborn baby, and during the lactating period, health of the baby, right? So there are several goals, there are several targets, and we hope that in the coming years, governments will take care of, societies will take care of, people will take care of. And one last thing I would like to talk about here is this, that reproductive health actually is interested in making health of women, or making issues related to reproduction, or making issues related to use of contraceptive, or issues related to pregnancy, abortion, marriages, very open, so that a proper education could be provided to people, so that proper awareness could be created, so that the contribution of the society could be made in a positive way. So not only reproductive health talks about health of women in a very scientific way, but it also talks about population control in a very scientific way. And from this point of view, population control, it is one of the important priority of the state. And that is why the state has tried to incorporate this topic in as many syllabus as possible. And this is considered as an important component of uh, adolescent learning also. So with this uh, points, we can conclude the discussion here. This is an evolving topic, and as we stated earlier, this is interdisciplinary. So there are many other things, many other models, many concepts and theoretical things are available. But within a specific period of time, we have tried to include as many points as possible. Thank you very much for being with me. Now I am closing this.